We are launching the new EPIC Evolution 1.0 at ASA conference in Perth this year. For those of you going to Perth, this is a great opportunity to come and see what is new on the EPIC, because there are so many exciting new features, functions, and image quality enhancements to discover. I know I'm very excited about the new EPIC ultrasound system. There are 3 key areas that have literally transformed this system. So we've got new micro CPA, outstanding penetration on every single transducer, and especially with harmonics imaging. And lastly, we have new functionality that makes your workflow much more efficient. Philips has enhanced 70 presets with image quality as well as workflow improvements. So it's quite exciting. The new micro CPA has been introduced to every transducer and every preset on the system. Micro CPA is basically power Doppler on steroids. It has a brand new algorithm that makes it possible to see fine vascular networks and those tiny arcuate renal arteries very clearly. You can see in this slide the previous software, power Doppler, compared to the Evolution 1.0. The arcuate arteries are so detailed, they actually look feathered, crisp, and well contained within the vessel. What we've done is we've actually canceled out the noise you see in the tissues surrounding the vessel and accentuated the color sensitivity within the vessel. We scanned this kidney in the office a couple of weeks ago and compared it directly to the IE22. So the IE22 is the image on the left and the EPIC Evolution 1.0 image is on the right. And you can clearly see the difference in penetration and the power sensitivity. We're actually visualizing vasculature at the back posterior aspect of the kidney, more so compared to the IE22. Color Doppler also has new algorithms, making it much more sensitive. So you can see in these 2 comparisons, IE22 on the left, EPIC on the right. The IVC is actually horizontal, and we are getting complete color fill compared to the IE22. And I'd also like you to note the 2D image is maintained behind the color image. And this is one of the most exciting things I think about this release is the penetration. You will no longer have to suffer the consequences of penetration loss and having to change transducers in order to penetrate. And you can now use higher frequency probes and still get incredible penetration. So you've got improved fundamental and less optimization needed while scanning. And really, when you turn the harmonic imaging on, it really does preserve the image quality. So that's, to me, the most exciting thing about this new release. This is the future of the EPIC ultrasound system, and there's only much more to come. So those of you who do have an EPIC, you will be receiving these enhancements in the very, very near future. So let's move on. During the webinar, all of your microphones will be muted. If you would like to ask a question, please type it in the chat box below in the bottom left-hand corner. At the end of the webinar, I will go over each of the questions and get Anita to answer them. And if you do have any more problems, just let us know. So I had the privilege of meeting Anita at the ASM New Zealand conference last year. She is a New Zealander with a wealth of knowledge, especially when it comes to renal arteries. She's had 15 years of scanning renal arteries and kidneys in the public and private sector. And along the way, she's also learned quite a bit about hypertension and how the renal artery fits into the entire picture. So please, let's welcome Anita. Thank you very much, Anita, for joining us tonight.
Hi, everybody. Welcome. Now, we've got, I'm just pulling up the slides now. I've got a wee green pointer, so I'm going to use that and direct you to what I'll be discussing. Now, to start with, there's so much to talk about. I've put an order of the day, so I'm going to start with some clinical indications. Then we're going to review the anatomy. Some of these things, obviously, you'll be read and know about, but what I'd like to pass on is just what I've picked up over the last few, many years of doing these, including the tips and tricks, measurements, the pathophysiology of hypertension, some cases, and the extra stuff. Now, starting off with, we're all aware of the general clinical indications. These are the common things that we see through from GPs and things. Obviously, hypertensive patient or uncontrolled, abdominal bruit, or when the plasma renin levels, and renal failure. So they're common. Now, what I am actually involved in is working for a cardiologist. I get my clinical indications narrowed very significantly. I actually don't do renal artery Doppler on all hypertensive patients, only a very specific group. So this is the group that the cardiologist actually asks for. So anyone under the age of 40 and even mildly hypertensive, absolutely we look at. Greater than 40, pulmonary edema, or if the blood pressure drops rather quickly with an ACE inhibitor, or is accelerated or sudden onset, or resistant to hypertensive drugs. And they must, when the cardiologist describes resistant to hypertension, they mean they're on at least 3 agents, and this is still not controlling the hypertension. And one of those agents is usually also a diuretic. And now the renal artery Doppler study, the cardiologists don't generally ask for them in diabetic patients. They don't consider them helpful. Although in the GP referral base, we do get a lot of them. Yeah. Now we're going to review the anatomy. So as you remember, these are retroperitoneal structures, arise around level L1 to L2, and off each lateral aspect of the aorta. Now, 25% of the population have more than 2 renal arteries. Now, I'm going to be going over this quite a lot because it's a little bit more significant than people realise. So that means 1 in 4. But do we see 1 in 4 on a renal artery Doppler study? No, we see a lot less than that. So the right renal comes off about 11 o'clock and the left comes off at 4 o'clock. And just to remember that your renal veins are actually anterior to the arteries. And so this is important when knowing how to set your colour, because you can have, if it's set too low, then you've got a renal vein bleeding over your artery and not allowing good visualization. Now, just a really nice example of multiple renal arteries, and as you can see how significant it's perfusing a single artery. Sorry, I'm just going to pull my arrow. I know what I've done. Are you there, Shelley? If my arrow, sorry. Start again with my arrow. Stuck. Are you able to help Shelley at all? Thank you. Cool. Got it now. Thank you. As you can see, this accessory renal artery has significant perfusion to the lower pole. So remember that for when we come back to that later, because as you can see, it's not as full perfused from the main renal artery in the lower pole as it is in the upper pole. Now on ultrasound, this is from the IU22, I think. But this is a classic case of, you can see 2 left renal artery origins, and on the right you can see a very early bifurcation. You see 2 renal arteries, but it's got a main origin with 1 and 2 branches. Now, so what I'm going to do is now going into patient preparation. The common preparation we all recognise is 6 hours nil by mouth, or commonly is nil by mouth and water. I do a little bit different from that because my aim is to reduce the gut gas but increase the perfusion. Now I find that 6 hours for me, patients start swallowing air, so I actually do it for 4 hours with no food. Continue normal medication, and I want them to drink 4 large glasses, but I don't want them to hold. I want an empty bladder. Well, not empty, but I don't want them uncomfortable. And then what I usually do is I actually ask them to take a short walk. So if they're parked in the bottom car park, that's what I'm after, because I want, like I said, to decrease the gut, but a little walk and a little water increases the perfusion. Yeah, and optimizing the scan, I do a number of things. This renal artery Doppler study is a challenging exam. So the probe selection is in the vascular preset is just my starting point. I adjust quite a few factors. You can actually play around yourself and maybe set your own presets. You start with your vascular preset, and at the end of that particular scan you've done, if you think that this has been really helpful and you've adjusted and fine-tuned everything, save that preset and remember that the habitus of the patient, and you may need a couple of these, but that's what I generally I'd recommend. Now, in positioning patients, I actually start with the patient right up on their side and then ask them to drop their top hip back so it opens out the flank, and using on the right side the liver as a window. So you come up right up intercostal, and as you can see, this is an ideal patient here, but you can actually see this is aorta and main renal artery, and you can see that I've tipped the patient quite a lot because this is actually a vertebral body here. Now, the origins, I do obviously start in the centre with them first lying flat for the origins, but you can actually get the whole renal artery from the right window. And also you can even try it from the translumbar approach. When you go really quite posterolateral, you're away from the gas. Even though it's further away from the probe, you actually move away from that significant abdo gas that really makes it very difficult for us. Now I do the same thing on the left side as well. It's a good way to achieve this is actually a Planck method. So for example, if you were in B mode before you even put colour on, line yourself up so you can actually see the abdominal aorta from a very coronal plane and the left kidney. And then from there, you can put colour on, but what you've got to remember is you get beautiful views all the way through, but you have foreshortened the renal artery. So just remember that, and use Inspinex to, and you'll find that depending on the size and habitus of the patients, you actually get an S-bend in it from a coronal point of view, and then if you that straightens it out, and you so have a look and look in real time. But it's actually a really, really good way of seeing the left, because you've got the liver as a window on the right side. There are suggestions in books that you've read probably a spleen as a window, but that's never been possible. I have never been in a situation where I've been able to use the spleen as a window. I think this translumbar approach is been very, very successful for me, and I've managed to see it pretty much every time. And you might be further away from but there's no bowel gas. My next thing is, now this is all our physics stuff, which we're all familiar with, but is still extremely important. So we want a reasonable degree of contrast, so we really want those black and whites and less greys. And so I adjust the overall gain, and you remember from the previous image how black and white, and I can actually see at depth the aortic vessel walls. So that's how I select my overall gain and dynamic range. Now, what you've also got to remember is if you are dropping your dynamic range and reducing it significantly, it's not ideal to assess the renal parenchyma this way, so you need to really optimize your renal settings again if you're just looking at the ecotexture. Now, just a good example of dynamic range. As you can see, with a lower dynamic range, how crisper the interfaces are in comparison to. So as you can see, it does significantly help you. Now, the colour box. I still use a reasonably small colour box. I still think it is important. I know our machines are absolutely fantastic these days, but with a wider colour box, you in a cardiac cycle, especially with someone with a lower heart rate, you can show systolic and diastolic in the same frame if you've got a wide colour box. And a lot of these patients that I see are cardiology patients with a number of other cardiac issues, so it does, I always find it does matter. And all the classic, heel-toe angulation of the probe, and rolling the patient around and finding that best window, obviously. Now, the colour gain. Now, setting the colour gain. Now, this is really important at the beginning of the study. What you've got to do is set it on your aortic value. So you want to, obviously, a moderate to high level with obviously young patients, and they might have a peak systolic aortic velocities of 70 to 120 centimeters a second. So you're in the moderate to high. So you set your colour cycle at the upper portion of that colour, but no aliasing in it. And you get wall-to-wall, but without aliasing, so that then you know that when you are looking at the renal arteries, you're getting true aliasing, not artifactual aliasing. Now, this is a lovely example of setting your colour correctly. As you can see, you've got the colour set in this pretty much mid to upper portion of that in comparison to, and you can see at 46 range, whoops, no, oh. Setting the colour scale a little lower, you can see how you've got aliasing in a normal vessel. So it is important to set this colour accurately. Now, your pulsed wave scale. Also, and similar to colour, you want to show that the waveform it takes up approximately 2/3 of your channel, whereas here it's set too high, so you're not actually being able to interrogate the actual shape and contour of the waveform, which is important later when you're looking for Tatus Parvis changes. So yet again, these are all these simple things, but I am fussy about when I set everything correctly, it doesn't necessarily make it easier examination. It just makes it an examination where I've actually got the information that I'm really happy with what I've seen. Makes it a successful one. Now, this is my pretty much, you call it colour right priority, but it's my top priority as well. As you can see, this is a normal colour priority set for a vascular setting. Now, I actually wind it up to maximum, so there's been no difference between these two slides. The only thing is writing more colour over black and white. And so here you've got this a lot more colour without actually getting any artifactual noise by turning up the gain. So a big key thing, and I always, the minute I get into that, before I do anything, I wind that straight up. If it's all, you just get your preset set so that it's already there. So here we go. Like I said, it writes more colour over the grayscale. Because we've got these strong reflective interfaces like gas and now our stents, you may not get any colour fill in a stent, but does that mean that it's not patent? No, because it's just not displaying the echoes. Now, sample volume placement. If you gain a coronal view of your kidney, you will always get a great image. Basically, it's a textbook where you want to show your renal artery and your segmentals coming off. Now, when you get the coronal views, when you come round, it's very easy to get this. Now, because what you really want to do is you really need to put your Doppler sample volume in the proximal segmental artery, so immediately after they bifurcate. If you get too far down, then you may lose your Tardis Parvis changes. And now, as you know, with the indirect calculations for the renal arteries downstream, we are looking for at resistive indices, acceleration time, acceleration rate. So these are all angle independent. So I never bother with angle at all. Sweep speed. Yet another, what we wanted to be able to do is we want to see a nice clean upstroke and look at the whole waveform. Now, so you want to set your sweep speed about 3 to 5 cycles. Now, if you're getting multiple ectopics, you may need to show a few more in your slide, in your trace, because you want to be able to pick the same place each time to measure. So if it's full of ectopics, you want to measure the same ectopic. Now, this is when ratios are really important for your Doppler criteria. This 180, greater than 180 centimeters can be really inaccurate, especially with those ectopics. Now, normal perfusion of the kidney is actually a continuous forward flow. So you should get half the diastole and then systole. So that is, so roundabout, so if you look at that with half of diastole, without even doing the equation, we know that that's about 0.5. And as you can see, 0.5. So that's a normal resistance just by eyeballing it. So a better way of saying it is the diastole is twice, the peak velocity, is twice that of diastolic velocity. Now, a normal waveform will have a very sharp upstroke and then a nice good deceleration. Now, renal arteries actually have a presystolic notch. If you're not sure where you are, you may end up, especially in the left and the right side, you think you're in the renal artery, but you actually may be in an SMA or celiac. It's closely related. So they actually don't have presystolic notches, but the renal arteries do. So that's another hint to if are you in the right place or not. Now, our direct findings. Ideally, we'd like to see the entire main renal artery. A challenge, yes, but that's our ideal. So we want to look at the 2D changes, look for, our key thing is the aliasing of colour, and then we're using our Doppler, a pulse wave Doppler, to look for those peak systolic velocities. Now we want to sample in the origin proximal mid distal. Now I quite insist on the origin and the proximal because if you can get a normal velocity prior to a stenosis, then the criteria is actually a Crossman criteria, not the criteria of the equation for renal arteries. And this actually occurs in a similar position in the carotids. The Nassek criteria with the equation may not be the most accurate velocity. If there's enough of a origin to take a sample in, and then the proximal is a stenosis, then you're using that as your ratio, which is a 2-to-1 ratio to get 50%, not a 3-to-1. I'll go over that again later, but being able to Doppler in these two are significant. Now, indirect findings we're after is our upper, mid, and low segmental arteries, and it's immediately after the bifurcation. Now, other indirect signs obviously are our size, our resistive indices, acceleration time, and acceleration rate. So I'm going to go over those individually as we go through. Now, Tardus Parvus changes. Now, this is where we get a longer acceleration time, and then a rounding of the peak and a diminished amplitude. Now, this is because the waveform has lost power, so this indicates a proximal stenosis, and this can be anywhere in the body. You can use these, and as you can see, you get feathering of the waveform, and you get filling in of the acoustic window, because you've got in that sample volume, you've got a number of velocities, of mixed velocities in that sample volume. Yeah, resistive indices. A soft sign. Now, with diabetic patients, they very commonly have small vessel renal disease. So they're commonly greater than 8. And so renal Doppler downstream changes may not be specific in a diabetic population. So it is they're the cases where it's even more essential to have a direct visualization of the main renal arteries. Now, HiQ. I generally don't use HiQ because it's a little bit inaccurate and it's averaging. This is the same patient, and as you can see, by averaging it, it's 0.77 RI, whereas it's 0.74. And as little as that may seem, it's getting close to the 0.8 cutoff, but this really is, when you look at this waveform, it doesn't look high resistant. Now, acceleration time. So this is a measure of the first initial upstroke, and that I would like to emphasize quite a lot. So it is from this point here to this point, not this point. So you want that first initial upstroke. Now this is where the scale becomes extremely important. If you scale a set inaccurately, then you're not going to see the whole upstroke. You may only see just the peak, and so measuring an acceleration time from here to here would give the impression that it was delayed, which is a false positive. Now, yet again, this is me and my scale, just to give you an example, how difficult it is. And this is actually the same patient. And as you can see, when I've set the scale correctly, I can see the whole upstroke, whereas here it's actually very difficult to see. And I think it might even be if you look from here to there. But if you weren't really assured of that, then you would actually measure up to here. So scale is everything. Now, acceleration rate. It is an additional piece of information, and not to be relied on in isolation. And I don't actually use it that much now. I'm not sure what other people and their experience is. But yeah, it's very more obviously the weaker of them all. Renal length. Now, uniformly by 50% or greater than 2 centimeters. Now, with focal areas affected, you can get focal shrinkage of the kidney, a very low yield to pick up, but be aware that that is one thing that's available to or should be looked for. And then also look at, you're going to get reduced renal function with cortical thickness of less than a centimetre. So that's going to, and with those patients, you're going to have a high resistance peripheral bed. Yeah, just a nice example which I've had for a long time, showing a normal side with a quick acceleration, pre-systolic notch, And you can even see that in the segmentals when there's a normal flow. And if you can see here, you've got a nice acoustic window, peak systolic. Looks like it's about 100. When in comparison to downstream, very damped Carter's parvis waveform, and then significantly high velocity. So it's just a nice example of that. Yeah, the next one. Now, arenal criteria. Now, we all know about the less than 60 and greater than 60%, and we've been using those and well aware of those for years. And so now this is where I've learnt something recently myself, which I actually got out of a vascular section out of my cardiac book of all. Now, they now use also another criteria. We can automatically put something greater than 80% if the end diastolic is over 150. So just something to be aware that yes, there is actually another criteria. So our less than 60 is the ratio of greater than 2 but less than 3.5. Now, our peak systolic velocities, yeah, they are important, but if you've got a peak systolic velocity in the aorta of, say, 100 centimeters a second, it's going to have to be greater than 350 to get a greater than 60% stenosis. Now, this is where the ratios become important, and now the peak velocity, peak systolic velocity, not so helpful. Whereas if you've got somebody with aortic flow of 50 centimeters a second, your ratios may not be helpful, but now your peak systolic velocity becomes into its own. So really look at the whole picture and not just that strict criteria. What does it look like to you? Now, don't forget, on the occluded main renal artery, you can have very low monophasic flow in the distal renal artery, just to be aware of that. Now, pathogenesis. Now, we all know about plaque atherosclerosis. Now, it accounts for 3/4 of renal artery lesions. Now, the most common is seen at the ostium or within 2 centimeters of the origin. Now, this is why I talked about if you can Doppler and get a normal velocity in the origin, but the stenosis is actually a little bit further down, then this is where you're using Crossman criteria of stenosis in a tube, what you'd use for lower leg arteries. And that's when doubling at 50, tripling it's about 75. So just be aware of that. Now, more common in men, occurs at branch points and points of fixicity, and there's either thickening of the wall or narrowing of the lumen. Now, in this specific group, if there's not much difference in the BP, there may not be any difference in the BP when treating them. We don't actually treat all atherosclerotic stenotic lesions in the renal arteries. It's a complex issue where they look at the hypertension, the blood, i.e. the renin, and how stable the hypertension is. Now, if it is a group, if it's a patient where the stenosis doesn't actually affect the hypertension, then we probably just sit on that and watch it for a while. We don't actually necessarily go in and treat all of these now. Used to, yes, but not now. Now, this is a nice example of, as you can see, catheter angio with a very, very tight stenosis and a peak systolic velocity of 430 centimeters a second. Now, on the newer criteria used, it does look tight here, but with the catheter in the way, you really can't actually tell. Whereas I want to show you another example of one that I've done recently, and this is actually a stent in the renal artery, main renal artery. Now this is a re-instant stenosis, and you can see the point of aliasing, and look how high I've actually got my colour scale, right up at 71. Sometimes I've even had it up at 90. It depends on the perfusion of the patient. So what you've got to set is that aortic flow first, and then you're going to know what's actually artifact and what's real. And here you can see that I'm getting an end diastolic velocity greater than 150. It's actually 185. So immediately I can actually put this into the greater than 80% stenosis. Now, grab what you can. This is more the ideal. And I haven't actually got my pulse wave gain up that much, but I can still get an impression of where you are. Now, as you know, these are really difficult with cases with people that have maybe short of breath or not able to hold their breath long. So if you have to do it 2-3 times, great, but just even if it's just one waveform that you've captured, take it, grab it. You can always delete later, but keep them all first and then select later if you need to. But I tend to keep them all because it shows it's more indicative of a pattern that's actually real. Yeah, this is actually a cine loop, and unfortunately we can't play it over the web, but you can actually see, what I wanted to show you nicely is you can see the walls of the stent and actually see there's some little hypoechoic soft plaque there and aliasing the colour. So you can actually just see that, and also you can see a dilatation post-stenosis of that. Now, a nice example of post-stenotic turbulence with the feathering. Very difficult in this case because it was that high grade, greater than 80% stenosis, where it's difficult to even measure acceleration time. We're not really after acceleration time anyway in the distal, but you can see a damped pars parvis changes. Now, this is why I showed you that perfusion image. If you can remember back in the first image I showed you of an angio, and it has a normal renal artery and a normal accessory renal artery. Now, knowing that 25% of the population, 1 in 4, has an extra renal artery, if you can see them, you must interrogate the whole length of it. But this is just a really nice example of yes, pars parvis changes are helpful, but I generally tend not to rely on them because this is the reason why. Now, this patient actually has an accessory, which was demonstrated in a previous angiogram, actually had an accessory lower pole renal artery. Now, as you can see, it's a normal waveform. Diastolic is half that of a systolic velocity. It's got a good upstroke. It's even got a presystolic notch. Now, in the same patient on the same side with that high grade, greater than 80% stenosis, we now have pars parvis changes in the upper pole of that kidney. So if you do have an accessory renal artery, remember that you get filling in from that accessory renal artery, you get good perfusion from that, so you're not necessarily going to get pars parvis changes. So that's why, yes, they are helpful, but I don't tend to rely on them at all. Now, another case is showing a high-grade stenosis. Here, you can actually see this is actually dilatation post-stenotic, and it was and this is yet again one of those cases where you grab what you can, and as you can see, the rest of my waveform is not ideal, but I actually have got one, and I did get another 2, but this is just one example of what I've used, and it is a high grade again. Now, a couple of older cases. Now, this one in particular, the right side, is actually less than 50% stenosis, and you can see on power here, there's just a little pinching in of this. And then downstream, and there's no tardive parvus changes downstream. Now, these are the cases now where, from a cardiology review, they may not treat this patient. If it is not the cause of their hypertension, if it's more systemic, then they will not go in and do this. So, yes, I may follow them on a yearly basis to see if they've got a good baseline, then only if their blood pressure spikes. Now, this is in bottom is another example of a greater than 60% stenosis, equal 30 centimeters a second. Now, my scale's not too bad, but it could be better, but I'm already low here anyway, and you have got tardive parvus changes. Now, the other group, which we know about, is actually fibromuscular disease. Now, it's only about 3% of renal hypertension. It's a difficult group to study because there's actually not a lot of data. Now, you can have fibromuscular dysplasia in the medium-sized vessels, for example, your carotids, renals, and be completely asymptomatic. Etiology is still unknown. It may involve segmental branches. It generally has quite a genetic and hormonal influence. And the other key thing is it can cause aneurysms and dissection. Now, FMD is helpful to treat. It is a cause of hypertension. Now, as we know, it can either involve the intima media or adventitia and involve fibrous thickening. And now you can get a string of pearls appearance or just one focal area. It may be unilateral, maybe bilateral. Now, this is a classic example of the string of pearls, the beading that you get, and the subsequent ultrasound image, and you can see the pinching in of a number of multiple stenoses. Now, even eyeballing that, you know that that's well and truly less than a 50%, each of them. Now, as I was describing before, you can have dissection and segmental artery aneurysms. There may even be an aneurysm of the main renal artery as well. That's a lovely example. Now, from a cardiology point of view, in atherosclerotic patients, there's about a 90% response. In the non-atherosclerotic, i.e. arteritis or FMDs and arteritis, 92% benefited, but only 42% cured. And so that case that I was showing you before of the greater than 80% stenosis, that wasn't an FMD patient, but just an example of with the complications that you can have with stents. And so her hypertension is not, or her disease is not really cured. Yeah, pre and post stenting. I think the most important thing is if you don't have a baseline, because you generally, I don't know what other people have experienced, but I used to get a lot of these cases where you'd set the baseline 6 weeks post renal artery stenting. Don't generally see them that much these days. They generally look at them clinically. So if there's any change in the BP, this is the most important guide. If you have got a baseline study, always use that. Now, the key thing to remember is these stents do lack compliance. So really important to, your peak systolic velocities are higher than a non-stented renal artery. And this is when your baseline really does help. Now, limitations and pitfalls. There's lots of these, as we know. Bowel gas, poor patient preparation, patient habitus. Now, the key thing is horseshoe kidneys and malrotated kidneys, really difficult. I had a case recently where this guy had a horseshoe kidney with ischemic changes on chronic ischemic changes from a dissection on one side, and then I had no baseline or anything to start with, and all his imaging was done by CT. They are the difficult cases. You're not sure what you're looking at there. Now, my experience. Now, what I think is the accumulative effect of multiple stenoses, i.e. from FMD, they generally don't cause tardus parvus changes. So relying on those downstream changes does not exclude a hypertensive lesion. Now, if you sample too far away from the bifurcation, when you have had a difficult case and you cannot really see the entire length of the renal arteries, you really can't rule out tardus parvus changes. And don't forget, tardus parvus changes, if you see them you don't actually have to do them in the segmentals, you are looking for them in the distal main renal artery as well. Post-stenting baselines are important if you're lucky enough to get hold of them. Now, if there's a segmental or branch artery that is affected, it will shrink the area, so just be aware of anything that's asymptomatic. I did talk about cortical thickness and less than a centimetre in possible renal vascular disease, particularly in diabetics. Now that is a tricky group of people. And yet again, I know I've said this a number of times, that multiple renal arteries can reduce or obliterate tardus parvus changes downstream. Yeah, hypertension. We know a lot more about this now. Hypertension is important to be treated. It's responsible for 1 in 6 deaths. Adequate treatment can reduce stroke, MI, and heart failure. Because generally hypertension in the chronic phase led to heart failure, and it's a significant group of people. And you probably remember a lot of people talking about their grandparents. They might have been treated for heart failure. Well, we now know that treating hypertension is important for reducing this big group here. Now, criteria of hypertension. Now we know is systolic 120 or less than 120, diastolic 180. Yeah, it is categorized into a pre-hypertensive and then stage 1 and stage 2. So these are the universally accepted definitions now of hypertension, what a normal is. Now, risk factors of hypertension: family history, age, gender, cholesterol. Now, lifestyle, i.e. too much salt, too much alcohol, not relevant to us. We've got enough potassium, we get that from bananas and tomatoes. Lack of physical exercise, the usual, smoking and obesity. So they are the key risk factors for hypertension. Now, primary or essential hypertension is where there's no specific cause identified. Okay. There is a rare malignant type, and these induce a number of potentially dangerous. Yeah. Secondary hypertension. Now, this is the category that we're involved in. Now, obviously, the first one, what we do is renal artery disease. Now, so I'm going to be talking soon about the renin angiotensin system. Now, the other key things that we're involved in with general ultrasound is renal parenchymal disease. So you may get requests that come through that don't actually ask for a renal artery Doppler study. They're actually hypertensive patients, but what they're really after is renal size. And what they really want to know is how thin or thick that parenchyma is. Now, coarctation of the aorta, so which is a stenosis in the right proximal as it comes over the arch and just pinches there. Now that's going to be the reduced perfusion throughout the abdomen. And then we're now getting into the hormonal, secondary hypertensive, and then the pheochromocytomas, which are the adrenal secreting, adrenal hormones, the catecholamine secreting tumours. Now, the kidney obviously is a dominant site of blood pressure regulation. The kidney is part of a feedback system. Obviously, it helps regulate the blood pressure, but because it's involved, it can disrupt it. And that's we're going to talk about the renin, angiotensin, aldosterone system. And this is the feedback system we'll talk about. Now, the detail. It is confusing. There's a number of, you go onto the internet and you can find a number of diagrams and things. If you're really interested, go and find something that is specific to you, because like I said, there's just so many wheels and circles and things. Now the key thing is angiotensin. It starts with secretion of renin into the bloodstream. Now, that obviously renin is what we, and along with a number of other things that we can give patients blood forms to check. Now, this renin is secreted by the juxtaglomerular cellular cells, in the kidney. Now, this renin acts on angiotensin. Now, angiotensin 1 is then converted by an angiotensin converting enzyme, ACE. Now, we'll come back to that a little bit later, and this is why I've mentioned this, is because I'm actually going to talk about some of the drugs, and this will finally start clicking and working and wondering how these fit in together. Well, this is where it comes into. So angiotensin 1 is converted into angiotensin 2. Now, this angiotensin 2, now this is your vasoconstrictor. Now, it's a hormone that acts on the smooth muscle, and it also increases the cardiac contractility. Now, it also acts on the sympathetic nervous system as well. So it does a number of things, this angiotensin 2. It also stimulates the adrenal glands to secrete this aldosterone. Now, aldosterone then acts on the renal tubules to maintain plasma volume and indirectly affects the BP. So the key thing here is, what you've got to remember is, angiotensin is a strong vasoconstrictor and it directly supports the blood pressure. It's just at what direction it's going in, up or down. Now, like I said about diagrams, this is one of the ones that seems to work with my brain. So as you can see, renin, the increases in the renin sets off the angiotensin, which then converts angiotensin 1 into 2 through the ACE. And this is where you get your negative feedback, because then angiotensin 2 then, as a vasoconstrictor, acts on the angiotensin. Now, this whole group over here with the increase is aldosterone is another group completely, which I haven't really gone into because it's all a lot of the bloods and things have to be incorporated into the talk for that, and that's another huge group. Yeah, just a quick thing about, because I also mentioned the sympathetic circuit. Now, it acts on the afferent efferent nerves, and here causing a sympathetic vasoconstriction. So yet again on the smooth muscle here. Yeah, you'll in a few moments you'll understand why I brought this up. Now medical therapies. Now this is the key. Now diuretics. Now we all know what they are. Now they reduce a fluid load. So by reducing the volume, therefore you reduce the pressure. So that's one type of drug. Now your other type is a beta blocker. Now that blocks the adrenaline system. So this acts on the sympathetic nervous system. It's also good for an anxiety state. Now this slows the heart rate and reduces the peripheral resistance. So this is what a beta blocker does. Now calcium channel blockers, they also reduce the pressure in the peripheral vessels. Now this is where that and so we often hear patients who are on ACE inhibitors. So if you remember that cycle, this is where they get their name from. So what they do is they actually relax and dilate the vessels and therefore reduce fluid retention. So that's how an ACE inhibitor. So these drugs, they activate at different parts of that circular system to try and feed back into the system to vasodilate but rather than vasoconstrict. Now there are drugs being developed all the time, and the latest group of drugs is the angiotensin 2, and as you can remember from that cycle, it also acts like a blocking agent but acts in a slightly different way. Yeah. To those of you who also do obstetrics, I wanted to put one slide in and just remind you that about preeclamptic toxemia. Now, it's the most common form of secondary hypertension. Develops in 7 to 10% of pregnancies. Now, we are seeing, as time goes by, a lot more of hypertension in pregnancy. So it actually invades cytotrophoblasts and actually invade the spiral arteries of the placenta, causing ischemia. So remember that this is it causes this unknown agent to vasoconstrict. So this is going to vasoconstrict the small spiral arteries of the placenta. So hypertension in pregnancy, as you can see, is an issue, and I do get patients through in the earliest stages under one of our cardiologists she's the foremost for hypertension in young women and pregnant women, and I've not ever had to do a renal artery Doppler study yet on anyone over 12 weeks pregnant, thank goodness. That would be even more challenging, but the key thing is that preeclamptic toxemia. Now, something we're not really involved in either, but I just wanted to discuss and just so that you're aware of what happens now with Holter or BP monitoring. It's a cuff that takes it's connected to electronic box just as a necklace, and obviously the cuff on the arm. Now it takes 2 measurements an hour during the person's waking and 1 overnight. And this is done over a 24-hour period. Now they average about 14 measurements, and what they want the patient to do is take a daily record and any exercise or medication and monitor it. Now, Holter monitoring is not actually just for diagnosing hypertension. It is really good in the cases of white coat syndrome. What I've read recently and been told recently, anybody with white coat syndrome has actually got a higher risk of actually developing hypertension themselves, which I didn't realise, which was yeah. So with Holter monitoring, now it's not, like I said, it's not only diagnosing, but it's if they on the medication, they can use it to actually monitor them and see if their medication's working. So there's a number of ways they can use it. Yeah, just a quick thing I wanted to show you what else we look at when a hypertensive patient, and this is common particularly this is the echo. So we look at the left ventricle in particular. So I'll show you some images in a moment, but left ventricular hypertrophy. So that's actually thickening of the left ventricle muscle, and you can get atrial dilatation, and then you can get aortic root dilatation, which makes it increases people's risk for aortic dissection in an untreated hypertensive patient. There are a number of other things, but these are the three most common they talk about. So I'll show you examples. Yeah, as you can see, this is to those who've not seen an echo before, this is the apex of the heart, the left ventricle, the right atria, left atria, right ventricle, and this is the septum between, and you can see the crisscross. Now this is a normal left ventricle cavity, but as you can see, the muscle is significantly thickened, especially when you compare it to, well, the right is generally a thinner muscle anyway, but if you have a look, I'll just by eyeballing it, it looks very obviously thickened. Now, this is the aortic valve, and this is what we call the sinuses, and then ascending aorta. Now, a normal ascending aorta is actually between 2 to 3.5 centimeters, and as you can see here, it's actually greater than 4. So this is a dilated sinuses and ascending aorta. Now, this is because of as this enlarges, it becomes more risk of dissecting. Now, you can see side by side, right atria, left atria, and you can see significant differences in size when the normal range is between 9 and 20. So that heart is having to work a lot harder. It's having to try and force more blood through the left ventricle and out, and so the back pressure is dilating up the left atria. Now, this is why I talked about the sympathetic nervous system. Now, renal denervation has actually been around for 50 plus years. They actually used to do it under surgical, and it was quite a brutal surgery. As things move along with the modern technology, they went to catheter-based renal denervation. So this is where they ablate the sympathetic nervous systems that run along the renal wall. Yeah. So what they do is they treat in a circular pattern. And so what they're trying to do is actually turn off the sympathetic nervous system so that it will try and decrease the blood pressure. So we do it, and it's done along the length of the vessels. Now, post-procedure, if you ever ultrasound there, what you're really after is actually patency and dissection, and obviously any groin hematoma or false aneurysm from post-catheter procedures. But this is the key thing, is patency and dissection, particularly dissection. Now there was a big trial, and it failed to meet its primary points. And so the key things were the drug changes, and the population didn't respond to this, and there were too many inexperienced operators and too few burns. So this catheter examination was at this point is stopped in the market. Now, what is on the horizon is actually an ultrasound guided system, where The catheter base was from internal delivery, i.e. a catheter inside the artery. Now this is from delivering energy from outside the body and in a blatant area. So, and they actually use color Doppler ultrasound to locate the renal artery. And this is a basic small ultrasound unit in the table. So thank you very much for listening. I hope I passed on as much as I could and that everybody got something out of it. And if you've got questions, please ask away and I'll try my best to do so.
Thanks, Anita. That was really great, and you're so lovely to listen to. Your voice is beautiful. Anyway, so Yvonne's got a question. So she wanted to question the fact that you get the patient to go for a short walk, but she's wondering if this makes a difference in the flow in the aorta. She's had a case where the reading in the aorta was high initially and then was lower later in the scan. What are your thoughts on that?
I haven't experienced that myself yet, but I do understand what she means in those vascular paths. I don't want them doing a huge run round the park or a huge walk. I basically just want them walking up from the car park. I just need a 5-minute, rather than straight out of the car and into the rooms. I just need a 5 to 10 minute, walk. Yeah.
Okay. So we've got another question from Joe. So with diabetics, how often do you actually see a renal artery stenosis?
To be honest, I actually can't think of anything off the bat because with diabetic patients through the cardiologist, they actually treat the hypertension first, and then only then would I be asked to Doppler them if the hypertension was not successful in its monitoring and treatment. So to be honest, I don't think I've actually scanned a diabetic patient through the cardiologist ever. I only get them through GPs, and in those cases, gosh, I've probably only seen one in 5 every 5 years, 1 in 5 years maybe, barely.
Okay, great. Thank you, Anita. Is there any more questions?
Sorry, I'm just going to add to that, and I think the reason for that is because with the diabetic patients, they've got so many other things going on that they've actually usually had catheter studies and vascular and been through vascular labs and had catheter studies, and they've noted stenosis at the time when they've actually done angios and angioplasties. So maybe that's why I don't actually. I had not seen, one in a while.
Okay, great question. I've got another question, Anita. In patients with a high BMI, given that 25% of people have multiple renal arteries, is it reasonable to conclude that a CTA in the hypertension workup if a patient has normal renal function? Is it reasonable to include a CTA in the hypertension workup if a patient has normal renal function?
Yeah, I do. If they're really serious about it, then and it's an uncontrolled hypertension, then yes, those are the ones that through the cardiologist, yes, they do renal CTAs on them. They will assess the patient and do send them for those. But it's the key things are obviously because it's contrast and radiation that it has to fulfill the cardiology requirements, not the GP requirements. So those particular patients that have, the resistant hypertension, You've already been on at least three types of medication and good doses, because that's the other thing that one of the, Fiona Stewart, she's the hypertensive specialist cardiologist. Her key thing is they might be on 3 drugs, but they're not high enough. So she adjusts the drugs and increases it, and then if they still don't, then they definitely do a CTA and not an ultrasound if it's in a case where they don't think that I would see that well.
Okay, thank you. Another great question. Another one, how useful are high resistive index values to determine abnormal perfusion?
They are our key thing in ultrasound that we've got. They are our tool, but you do need to know a lot of history, patient history, because renal resistive indices and segmentals and arcuates right out, they increase for a number of reasons. It might be that they've got increased pressure in the Bowman's capsules and things from medical renal disease. It could even be a transplant kidney, so is it a rejection kind of thing? So yes, they are important, but they're not very specific on their own. You really need that good clinical behind you to narrow it down a lot more. Does that help? Does that answer it?
I think that answers it perfectly. Thank you very much. So if there's no other questions, then I would like to say a big thank you to Anita. We really appreciate it. That was really great. Lots of interesting information there, and I'm sure that people who are just starting out with renal arteries to experienced people would have gotten something absolutely for sure from your talk. So I really appreciate that.
Thank you. I've actually really enjoyed going through all my stuff and putting it together.
Yeah, it was excellent. So for those of you left, our next webinar is going to be Wednesday, the 6th of May, and that's for testicular with Mark Smith. So again, thank you everyone tonight for joining us, and if you have any questions, please email me. The recording to the webinar, I'm just putting it in. You can copy and paste that and